Hi, and welcome to this presentation on integrated laparoscopic operating theatres. So the aims of this presentation are firstly to understand what an integrated laparoscopic theatre actually is, then to review the components and features. Included in this, I'll also be looking at considerations taken into account when designing an integrated theatre. Then the final aim is to discuss the advantages of these theatres. So what is an integrated theatre? In the context of the operating room, integration refers to functionally connecting all aspects of the theatre environment. This includes patient information, video, audio, room lights, and medical equipment, to name a few. When integrated, all technology can be easily manipulated from a central console by one individual. Integrated systems are user-friendly and aim to help the entire surgical team work in a more efficient and safer way. But why are they needed? Well, primarily they're needed in order to best support minimally invasive or laparoscopic endoscopic procedures. These are modes of operating that have become increasingly popular over the last few decades, in particular with specialties such as gynecology and general surgery, with the hope of only increasing their use further. It therefore makes sense to have an operating theatre which can accommodate the new available technology, as well as supporting the likely future developments. Another reason integrated theatres are needed is to eliminate the complex wiring systems and clutter in theatre. In a non-integrated theatre, there is typically an assortment of equipment arranged around the surgical table, with individual pieces being pushed forward or pulled back as needed. As shown in the picture on the right, this results in wires being draped everywhere and clutter around the table. This brings into consideration health and safety concerns, whereby wires and cables are running under the patient table, in the path of theatre staff, under the feet of the surgical team and anaesthetist, therefore creating trip hazards and increasing the risk of equipment being unplugged or damaged, all of which have the potential to disrupt the surgery. However, in integrated theatres, wiring and cables run inside the articulated ceiling arms for the lights and monitors. This means that there are no wires or cables running along the floor, allowing a smoother workflow to the surgery. Typically, there would also be a circulating nurse changing any settings at the surgeon's request. So these are things like light positioning, pressure on the insufflator, or taking pictures mid-surgery. With an integrated system, all of these are able to be controlled from one central control system on a touchscreen, with even the ability for the surgeon to have a command console and change the settings within the sterile field. So in terms of the design, it should focus not only around current but also future goals of the hospital. So this can include things like increasing patient safety and satisfaction, efficiency, and being able to adapt to future technologies as they progress. Firstly, design should take into account the types of procedure and medical devices being used. For example, a gynecological laparoscopic theatre will have different requirements to a general laparoscopic theatre. The room size is also an important factor to consider. Even though there is less physical equipment, generally the theatre needs to be increased in size by around 15%. This is to accommodate free movement of the monitors, the lights, the ceiling arms, and also accommodating the new screens. It's also important to recognise that there are some challenges associated with an integrated theatre design. So compared to less detailed images or videos, today high-resolution media files are generally larger and require a lot more data storage. To ensure that adequate storage is available, planning for an integrated operating theatre includes defining these requirements. You also need to ensure that you've got the bandwidth availability and the correct network requirements to make sure that everything integrates as it should. So just to go through a few features of an integrated theatre. So you have these 4K 3D ultra high definition monitors, and these allow the surgeon to see the anatomy in far greater detail than they would be able to if they were doing the surgery open. So these monitors are then generally connected to these ceiling arms, as are lighting, and they also contain the wiring. So these are coming down from the ceiling and allow ease of movement. There's less clutter on the floor, so staff have more space to move around. Touchscreen control, so this can be done from both inside the sterile field and outside of the sterile field, and they're great for infection control because all they need to be done done is have a quick wipe down. Central control of equipment and room functions. So this is everything from the lighting, the insufflators, the monitors, what they show. Everything can be controlled from this one central system. And then there's also features such as video conferencing and documentation. So there are many types of integrated operating theatres on the market, and they all vary in price and complexity. At the most basic level, there is a VE level, which simply portrays the image from laparoscopic camera onto a local screen in the operating theatre. AVT systems then add teleconferencing into the mix. So this would allow for conference room presentations. AVER allows for easy access and control of all equipment, as well as video images to be played on 2 or more displays. This system also allows for music to be played from another device through in-ceiling speakers. All these systems are interlinked and allowing everything to be controlled from the central control unit. AVER-PI level is generally at least a level of integration in most operating theatres currently. This system integrates not only video, audio, medical and room equipment, but also PACS, which is Picture Archive and Communication System. And this allows for the theatre to be connected to other areas in the hospital, such as radiology or labs. This means patient investigation results, so X-rays, CTs, blood results, can be viewed on displays in theatre at the time of operation. And then finally, AVER-PIT level includes telemedicine, which connects the theatre system to the outside world. Conference rooms or lecture theatres around the world, or even just down the street, can see what's going on, which is greatly beneficial in terms of teaching and then consulting other colleagues on certain difficult cases. So there are many advantages of integrated theatres. Increased control of the theatre means the surgical team are able to work more efficiently together and hopefully reduce operating times. Of course, probably the most important advantage is that there's improved safety, and this is down to the lack of wiring. More equipment is easily moved, and the team have an easier flow through the theatre. The equipment is readily available, it is constantly set up, there's no need to be moving equipment in and out of the room, and it therefore leads to quick setup and cleanup as well, which reduces the time between operations. Better image quality is of course down to the 4K monitors. Even some of them have a 3D function, so this gives a perception of depth that you might not be able to get before. And again, easier to move equipment. This is thanks to everything being connected to the ceiling booms, and it's just a quick movement with your arm. So in terms of looking at the future of integrated theatres, voice control functions are something that are currently being used in some theatres, and this would be beneficial for the surgeon, meaning that they wouldn't have to touch anything outside of the sterile field, and they would simply be able to speak the command and the system would be able to respond. There's then virtual and augmented reality. So this is being looked at in training surgeons and clinicians, especially when there's a complex case and they might need to be able to practice beforehand so that when they come to the actual surgery, they are well prepared. And finally, artificial intelligence. This will be used to either establish diagnosis or in the future, maybe even used in guiding surgery. And that concludes my presentation. So thank you for listening.